Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai. And today we have Professor Mario Mosella. He's a well-known bariatric surgeon at the globe, no doubt. And also we can see Professor at any international conference. Professor is one of the person who is part of, who is the leading person, no doubt. And also we can see many guidelines and also this all his presentation we can see physically as well as also he has a lot of research work. So, my viewers, as you know, we have completed 4 interview series, and now this fifth interview series is going on. That is about revisional bariatric surgery nowadays. That is going more popular and more common. This is the time to talk about this, and in future we need some guideline from person like Professor Mario Mosella. Sir, please, over to you, sir.
Thank you, Dr. Abbas. Thank you, dear Imran, for your very friendly introduction. Well, revisional surgery in bariatric surgery is a must. Is something we are facing more and more as all bariatric procedures increase all around the world. So it's very common, especially if you are leading or if directing a center of excellence or a tertiary referral center, you have to face a complex situation of patients already operated elsewhere. In my unit currently, we have more or less, if I have to make a rate, I would say we have 40% of patients are OAGB surgery, 20% of patients is a sleeve surgery, 10% of patients is Roux-en-Y gastric bypass, and 20% is more or less the rate for revisional surgery currently. And well, we face any occurrence. Once again, it is very common to see patients already treated by sleeve or by lap band in the past years. They require often some kind of revision.
Sir, excellent. So now this is a big figure. So 20% of your routine bariatric surgery is revisional. No doubt this will be increased in coming years. Sir, we are interested also, so because personally I know you very well, but so our viewers also interested about your brief introduction and also so your experience, especially when you have started this revisional bariatric surgery.
Yes, well, as our experience started to grow, we started in seeing more and more patients requiring bariatric surgery. I would say that our experience with revisional surgery has started in the possibly 2015, 2014, more or less 10 years ago. And well, we are in that where we keep on doing this.
Sir, excellent. Sir, regarding, so if we define, so if we can now here, so now you have at least 1 decade experience of revisional bariatric surgery, but sometime in international conferences, so we hear conversion, we hear correction, we hear revisional.
Sure.
How you
Where
define?
we may face some confusion about the definition.
Yeah.
Well, in my opinion, well, with the term revisional surgery, revisional surgery is a revision of something that has been already done by ourselves or elsewhere. So it's a unspecific definition. We have, in my opinion, to classify the term revisional surgery according to timing and according to procedures. The first is according to timing. Make a revision in the immediate postoperative period, in postoperative day 1, 2, or 3, is a revision that often implies a concept of emergency. and this is the reason for what sometimes we are asked to perform some repair, and we'll talk about this in a few moments. Conversely, sometimes we are asked to revise surgery that has been done many months before, or even years before, for different kind of problems, as malabsorption or reflux. This is revision as well, but is a revision that is totally different from the revision we make in the emergency setting. So this is the first difference I would say we had to define: the setting in which we are doing our revisional surgery. Second, how we should define our revision. In my opinion, we have a different type of revision. If we have to revert or restore the standard anatomy that sometimes may happen in emergency, for example, when we have a leak coming from one anastomosis gastric bypass, if we have a leak at the level of the anastomosis, sometimes it may be safer to revert to original anatomy, make a gastroanastomosis and take down the gastrojejunal anastomosis. This is a reversal surgery intended as revisional surgery. Other definition is a conversion surgery. Conversion is when we transform something into something different. For example, the case is very well known when we turn one Y or one anastomosis gastric bypass, or sorry, when we turn a lap band into one Y gastric or one anastomosis gastric bypass, or when we turn a sleeve gastrectomy into a 1Y or into a one anastomosis gastric bypass. In these cases, we can define this as a conversion surgery. And of course, between reversal and conversion, that are both cases of revisional surgery, we have to consider, of course, also the repair. That is what we are asked to do sometimes in emergency setting. For example, for a perforated ulcer following one anastomosis gastric bypass or one Y gastric bypass. In these cases, sometimes it is enough to put some stitches or some omental patch over the perforation, and this is not a reversal to our standard anatomy or a conversion to another surgery. It's just a repair, and is the third level, I would say, of revisional surgery. So in summary, revisional can be defined according to timing, following emergency or not, and according to reversal surgery if we go back to original anatomy, conversion surgery if we transform in surgery into another, or correction or repair surgery if we are making a repair into during an emergency setting.
Sir, excellent, excellent. So definite, everything is now clear, especially for my youngsters. Sir, regarding this sentence, so failure of bariatric surgery, that always we hear at different platform, and especially from our patients. So this is very important. Expectation of the patient. So sometimes we are also involved because we talk with the patient. So yes, I will do this surgery. You will achieve this, and also especially comorbidities. That is also sometimes we talk them. Yes, when I will do so, then this diabetes will go, hypertension will go, and now we increase the expectation of the patient. So, what is your opinion about this failure of bariatric surgery? How you define this?
Yes, well, according to international convention or consensus, I would define the failure of bariatric surgery when we have an excess weight loss rate lower than 50%. This is the basic concept that I believe we should always attain to. And this is with regards to the weight, of course. And this is regardless from the expectations that patients may have. Of course, for patients regaining some 3, 4, or 8 kilos may be depressing, but we have to consider this under our point of view, that is the standard research point of view, that is once again being keeping an excess weight loss rate higher than 50% in the mid and in the long term. I mean, over 5 or even over 10 years. At the same time, we should consider what we can see about the metabolic part of our surgery, and especially with regards to diabetes. We know that according to the American Diabetes Association, we can talk about remission from diabetes when the blood sugar is below 126 milligram per deciliters, or when we have a glycated hemoglobin that is below 6.5%. And of course, sometimes the weight response, the weight rate and the remission diabetes rates are not running at the same time. So sometimes we can have a recurrence from diabetes by keeping an appreciable weight loss, or conversely, we may have a weight regain, but with the keeping an appropriate level of diabetes parameters. So, but in any case, I believe we should attain to the international conventional data, that is being below 126 for diabetes and keeping an excess weight loss rate higher than 50% in the mid-long term.
Sir, thank you. And also, especially for my youngsters, so when you are talking with your patients, so please be honest. And so this is the reality. When they know about this, when they achieve more than 50% excess body weight loss, it's okay. So not so when we talk with them, yes, you will lose 100% and you will reach like this. So then the expectation of patient so will be more and definite. And also this surgery, and also visit is a multifactorial. This is not only surgery. Then so after surgery also, how patient will deal, patient to patient differs. Sir, thank you, sir. My question regarding technical consideration, because in revisional surgery there is a thick tissue, there is a lot of adhesions, because we have at our platform this message is especially for our youngsters. So what is your experience now? You have more than 1 decade experience of revisional surgery.
Well, first of all, we should very cautiously keep in mind that these patients need a very appropriate indication to surgery. My first suggestion is, do not go for revisional surgery if there is no very clear indication to this. And this is the first step. The second one is, of course, when we have chosen to operate on our patient and there is a clear indication, we should consider where this patient comes from, which surgery he had received previously. Of course, it is not the same if we are going to revise a patient that has been treated in open surgery, and if we are dealing with a patient that has been treated before by laparoscopic or robotic surgery. Of course, we know that following open surgery, we may meet much more adhesions than what happened with the patient that has been treated by laparoscopy. And third suggestion is consider which surgery this patient has had before. I mean, revising a sleeve is not the same that is asked to us when we are asked to revise a band, for example. Band may be somewhat much more complicated to remove or to convert to another surgery than a simple sleeve gastrectomy, asking revision for reflux problems, for example. And this must be kept in mind very carefully by anyone who is approaching revisional surgery. Of course, then we can have the even more and more difficult situation, that is what we have to face when the patient has already had 2 previous or even 3 previous surgeries. And in this case, following what is the current vogue that we are dealing with and we are reading about in this period, we should consider even alternative resources as for example, the new analog of GLP-1 that can be very useful in managing eventual weight regain in patients already treated with 3 or 4 surgeries before.
Sir, excellent. Sir, regarding, because you have mentioned earlier, so in your practice, 20% is a revisional surgery, and we can see now at the globe, the most common bariatric surgery is a sleeve gastrectomy. In your practice, that in revisional surgery is most of them are sleeve to another surgery, or what is the dominant one?
Well, the surgery I am, well, currently I would say is 60 or even 55% sleeve, 45% band. You know, we are coming from a decade of lap band that has been the period going from 2005 from up to 2015, and now we are observing all the problem arise and following a band. So in my experience, once again, is 55 to 60% what I have to revise from a sleeve, and 45 to 40% what I have to revise from a band.
Sir, excellent. So regarding a sleeve gastrectomy or also band, so we face two issues, especially after a sleeve. Yes, in band, yes, personally also I face some slippage of band and also
Mm.
other complication of band. But in a sleeve gastrectomy, the main issue is weight regain or GERD after a sleeve gastrectomy. That one of these two main, other than, because we are not
Sure.
talking about complications, because we are talking about these issues. So my question now about insufficient weight loss after a sleeve gastrectomy, that is insufficient weight loss, that is the standard definition. And patient, so operation definite, your center is a referral center. When you evaluate, there is a dilated pouch that was not standard sleeve. So what you will do when you will go for surgical intervention now, 6 months, 8 months ago, patient first lose 10, 20 kg, then stop. And what you will do in this patient?
Well, yes, I agree. The most cases of revisional surgery needed following a sleeve is due to reflux, to GERD, or to weight regain. Of course, we have to consider these 2 different issues. For what it is about a weight regain, of course, we have to revise the sleeve. But what is surprising to me recently is I'm revising some sleeves already done in my center or done elsewhere. And not always, I'm talking about weight regain, of course, not always I see a sleeve that is very much dilated. Often I see a sleeve that saves its dimension, and conversely, the patients tell me that they are started once again, for example, to eat sugars or sodas or such elements. You know that restrictive procedures, as the sleeve is, are very insufficient when the patient starts once again, restarts assuming sweets or sodas or creams, or this is happening quite often in the last period. So in this case, I do not retrim the sleeve, and my option I offer to the patients is to turn the sleeve into a one anastomosis gastric bypass. Conversely, when there is a GERD problem, a GERD issue, with or without weight regain, of course, we should consider, before offering one anastomosis gastric bypass, we should consider which is the level of reflux we have in these patients, because sometimes we may have a very mild level of reflux. I would say a grade A or B esophagitis, and in this case, in my experience, OAGB is a very good option. But sometimes we can have different issues like C or D grade esophagitis, or even Barrett's esophagus, as we have seen and read in several papers recently. In this case, my option is not to offer one anastomosis gastric bypass, but conversely to offer a Roux-en-Y gastric bypass. This is what I do. So coming back to your question, if the sleeve is not dilated, I do not retrim the sleeve. But if there is a high level of reflux, a high grade of reflux, I do not offer a one anastomosis gastric bypass. That to me is the best option, but I offer a Roux-en-Y gastric bypass.
Sir, thank you. Sir, regarding this insufficient weight loss, and also we can wait till 1.5 years, and we can use some medicine. And also, what is your opinion about endoscopic plication or gastroplasty? And what can I say? Especially in a patient now,
Well,
8 months.
I must be honest. Um, when we all started with the sleeve, with this experience, we had to face a very harsh enemy, that was the leak. Okay, most of the leak we experienced at the beginning of our experience with the sleeve were probably due to some technical mistakes we all did at the time, and because probably we were not so used in laparoscopy to free the entire fundus of the stomach and to see the left cruise of the diaphragm. But now that we have learned how to do a perfect sleeve by saving a couple of centimeters from the is angle, and by doing a very scrupulous preservation of the vessels coming from the small curvature, in my experience, the leak rate has decreased to a very, very, very low rate, less than 0.5%. Why am I saying this? Why I'm telling to you this? This is because all the alternative techniques that have been proposed, and the endosleeve or the gastric plication are some of these, or I don't know, the barrier clip, for example, are all being proposed to, in a certain sense, to avoid the leak complication following a sleeve, because it's obvious that following an endosleeve you cannot have a leak, or by putting a barrier clip you cannot have a leak. But in my opinion, if you perform the correct and a clear sleeve, having a leak is very, very uncommon. So I am not a fan of these alternative techniques like the endosleeves or the gastric plication or the barrier clip. I leave some room for the endosleeves in patients that are not so able to receive general anesthesia or a very long general anesthesia, or they or if they have a very problematic contraindication to general surgery. But conversely, once again, I'm not a fan of this alternative technique to sleeve gastrectomy.
Sir, so much thanks. Sir, now just imagine we have a patient with weight regain after sleeve gastrectomy. Because before
Mhm.
we were talking about insufficient weight loss, weight regain of 5 years, 6 years after surgery. Just so for my youngsters, so when patient consult to you, yes, patient receive that ideal weight loss. Now starting weight regain after 5 years, 6 years, and now you have decided. So definite. So first you will go for healthy lifestyle, you will start some medicine and GLP-1. So this agonists are derivatives. So what is my question? In such a situation, patient did sleeve gastrectomy, that was standard sleeve gastrectomy at your center. Now weight regain, and patient is worried about this. Are you think maybe in future this endoscopic intervention will be another option? So we can give the patient this option.
I don't know. Probably you're right. I don't know. The time is a gentleman, as we say in Italy. So we will see in the future if these alternative approaches, non-surgical approaches, may work. In what do I do in my center when a patient comes to my observation with weight regain following a sleeve gastrectomy? I would say my first comment is that, of course, the first comment is this is up to the patient. I mean, if the patient is willing to recontrol his life and his lifestyle, we can make an attempt with GLP-1 analog or some dietary counseling as the very first approach. Sometimes it works, but more often this does not work. So the option remains surgery. If it is my personal conviction, if restrictive surgery has not worked, I do not go once again for a restriction. I mean, I never do a sleeve following a sleeve. I never do a sleeve following a band. If there's some weight regain following a restriction, I go for a bypass surgery, or even sometimes in a very few cases for malabsorptive surgery. And well, uh, waiting for other indication as the endosleeve, where I don't know, unless the gastric pouch of the sleeve is not very is very much dilated. I don't know if the endoscopy has enough room to perform an endosleeve gastrectomy in case of weight regain following the sleeve. So in case of weight regain following a sleeve gastrectomy, consider bypass surgery if the dietary counseling or GLP-1 analog are not indicated or not working.
Thank you. Sir, this case that now I am asking is a real case. Weight regain after sleeve gastrectomy, a male patient, but unfortunately heavy smoker. So definite
Mm.
patient need a male observative component, but there is no GERD, no GERD apparently, and there is no symptoms. He is no complaint of GERD. This is interestingly. We have three options. First option, we can go OAGB, but there is more chance of marginal ulcer in this case. We can go for SADI, said better than OAGB, because so when we will do duodenal or duodenojejanostomy is definite, there is less chance of marginal ulcer. And third one, we can go OAGB with truncal vagotomy. What you prefer in this case? Patient is
I would set a fourth option, that is going for an OAGB, but doing an antral resection. You know what I mean? When we turn a sleeve into an one anastomosis gastric bypass, we leave a part of the gastric antrum. You know, in the antrum, it is produced the gastrin, and the gastrin stimulates what is in the gastric pouch to produce acid, and this acid may stimulate, may favor the onset of marginal ulcers. And in the normal stomach, the gastrin production is hampered, is regulated by the flow or acid output into the duodenum. This is what it doesn't happen following a conversion of a sleeve to a one anastomosis gastric bypass. So the antrum keeps on producing gastrin, and the gastrin stimulates acid that is produced, but it doesn't pass through the antrum into the duodenum. So my first option, and what I currently do now, is to turn the sleeve into a one anastomosis gastric bypass, but to resect the antrum just 1 centimeter following the pylorus. So this is a sort of SATI without a pylorus. And in my, it's my opinion that the pylorus we keep following a SATIs, I don't know how much it is working. I believe this can be a good option to turn the sleeve into one anastomosis and to resect the antrum.
Sir, have you any data? So if we see, we remove this antrum, then there will be less
Well,
production.
I have so far no data. I started to resect the antrum in the last 2 years, so it's not very there's not many patients who received this passages treatment, but it is the very well known retained antrum syndrome. That is what happens when we leave the antrum of the stomach inside, but the gastrin production is not hampered, is not regulated by the flow of acid output. So by resecting the antrum, I believe we can have the same results we have with the SATIs by doing a technique that is in any case easier than the SATIs, because we don't have a manual anastomosis, and well, that's all.
Sir, this antral resection, is it your routine practice in revisional surgery or no, in selected cases?
No, this is currently becoming my standard treatment. In all the sleeves I convert to a one anastomosis gastric bypass.
Okay. Excellent, sir. Sir, regarding GERD, because you have also mentioned when patient is suffering with GERD after sleeve gastrectomy, and now you have decided to go for surgery. Any chance to do in any so this like links, or I have no idea, like this teres ligament?
No, no, please, no. I'm very skeptical about well, in general, you know, I believe that any new suggestion, any new proposal, any new technique should undergo the same trial that the OAGB has gone. You
Yeah.
know, me in Italy and a lot of Italian friends and the European friends worldwide have proposed and brought up to the attention of the surgical community the OAGB, and at the beginning we received very harsh criticism, but in the end, all the observation, all the experiences, all the conclusion led to the observation that the OAGB was a very reliable surgery. I expect for all other proposals or suggestions to treat them as the OAGB has been treated. The same attention. So when we'll receive positive signals from these experiences, can be the links or any other, the Barry clip or any other suggestion, following some years of experience, at that stage, I would say, okay, I'm convinced that this could be a good alternative. But so far, I'm quite skeptical, I must be honest.
Okay, sir. Okay, regarding sir again, so because these question are common question of from our viewers as well. So wait again. So you have decided to go for anastomosis, gastric bypass. Are you this we are talking about revisional surgery? Are you measure whole length of small bowel? And what is your study for BP limb or common channel?
Yes, this is interesting because, when I perform a primary OAGB, normally my pattern, my parameter, my guide is the BMI the patient has. Is the patient has a BMI that is between 35 and 40, is basically metabolic patients. Normally, I remain around 180 BP limb, 180 centimeters. If the patient is between 40 and 45, I remain around the 2 meters. And if the patient is above 45, is between 45 and 50, I go also up to 220. And this is as the BMI grows, the length of the BP limb increases. If the patient is between 50 and 55, especially if he is a male patient, sometimes I reach even to 50. And if the patient is between 55 and 60, I can reach even 3 meters from the Treitz ligament. But, and this is very important, in any case, 180 BP limb or 3 meters BP limb, before doing the anastomosis, I put a grasper on the point where I'm going to do the anastomosis, and I always measure I have at least 3 to 4 meters below that point. That this makes me in a safe position. This put me in a safe position and helps me to avoid any malabsorption. I'm not very convinced about measuring the entire small bowel. There is some very interesting papers that have shown that especially in laparoscopy, having a unique measurement of the entire small bowel, even when it is the same surgeon to do that, is very misleading. In some of these papers, you see that the same surgeons has measured seven meters at the first measurement, and for example, 8.5 meters at the second measurements. So I'm not convinced about the utility and the efficacy of measuring the entire small bowel. That also, and we should take in account this, may be even dangerous, because measuring the intestinal small bowel in a very fat man can lead to some misperceived perforation of the bowel, of the small bowel wall, and we may pay this in the immediate postoperative period. So if I'm doing primary surgery, or also if I'm doing a revisional surgery with OIGB, do not be not scared about reaching even 3 meters, but be always cautious and sure you have at least 4 meters below your anastomosis. This makes you in safe with regards to any malabsorption.
Sir, excellent. Sir, as you have mentioned, and I understand, with the elder age, your male absorptive component is more dominant. It will be 55, that is about 300, but in younger one is so this length BP is shorter as compared to older age. So why this? Because if we see when age is more, as I understand, if I am, so you can correct me. So if age is more than 55, then overall absorption is less, and we prefer to go.
Sorry, I was talking about 50 and 55. I was talking about BMI, not the age of the
Okay,
patient.
okay.
I was talking about the body mass index, not the age of the
Yeah,
patient.
it's okay. It's okay. Okay, sir. Okay, sir. Again, my question same. So, in your experience, so your patients are happy? They lose weight with this PP limb?
Um, yes, they do. They do. They have generally very good results following OAGB with different BP limb lengths, and they're not scared. They do not complain. I've seen just a couple of cases of malabsorption that I have to revise by shortening the BP limb, and but it has been very uncommon in my experience. I had I faced more troubles with some nutritional issues following uh, restrictive surgery than following the AGB.
Okay. Sir, regarding, because again, this is the main issue, again, marginal ulcer, GERD after a sleeve gastrectomy. My question regarding vagotomy, because I remember, so when we were resident and then earlier there was no PPI at that time, I remember this was common. So we do routinely this truncal vagotomy or highly selective vagotomy or
Mm.
so. Are you agree nowadays there is any place for such a surgery, especially when we are facing such a situation like marginal ulcer?
Well, I must be honest, I have no experience regarding truncal vagotomy. I started my residency in it was 1990, 1981, 1989, 1990. So at the time, the results we faced that we had with the PPIs were already very, very important, and the surgery of the peptic disease as was going to disappear. With regards to bariatric surgery, my well, we have to ask ourselves two questions. The first one is has the H. pylori in these patients been eradicated? And this is the first issue. So if I face some marginal ulcers or recurrent marginal ulcers, first one we have to go for a total eradication of the H. pylori with the standard protocols. The second is if I keep on having or facing some ulcers, even if the H. pylori has been eradicated, probably there is a technical issue. I mean, a lot of ulcers, especially marginal ulcers, comes from an insufficient blood supply of the gastric pouch or at the level of the anastomosis. So if if the blood supply is poor, we may face more and more ulcers and recurrent ulcers. And these probably, when the H. pylori has been eradicated, may require a revisional surgery, of course, in which the anastomosis receive a sufficient blood supply.
Okay, okay, sir. Thank you, really. And because this is the main issue, and sometime we also face intractable marginal ulcer in Roux-en-Y gastric bypass. Have you faced such a situation? There was no response. What you do? What you will do in such a situation?
I must be honest. I have an experience with the Roux-en-Y gastric bypass that is much smaller than the experience I have with the one anastomosis. So I sometimes use the Roux-en-Y as a revisional procedure following WGB or following sleeves, and I've never met such recurrent or intractable ulcers following Roux-en-Y gastric bypass. Probably at this level, we should consider before going for regional surgery. Of course, we should consider, of course, medical treatment, the eradication of H. pylori if it is present, and possibly the endoscopic approach to these lesions that may give us some good results.
Okay, sir. Regarding weight regain after Roux-en-Y gastric bypass, So definitely maybe you have some referral cases. Are you think about distalization?
Well, I believe that the answer may be the distalization. I agree with you, especially if the gastric pouch is small enough and your anastomosis has not widened. Well, sometimes it happens that the anastomosis gets larger, that widens, and in this case, of course, the endoscopic approach can be very useful if the anastomosis is as widened. But conversely, if our anastomosis is okay and the gastric pouch remains small, we should consider distalization, of course. I agree with you.
Yeah, sir, because I know so your main practice is one anastomosis gastric bypass. So have you faced any severe malnutrition and weight loss in your patients, and then you revise and
Yes, I told this you just before. Yes, I faced a couple of cases of malnutrition, and they have been treated by reducing the length of the BP limb, of course, and redoing the anastomosis. This is mandatory in these cases, even if I must consider, we should consider that in both cases, I didn't found a very small, a very short common limb. In both cases, the common limb was was longer than 4 or 5 meters. So it was not exactly related to the length of the common limb. In both cases, some malnutrition was seen following a gastrointestinal infection that these patients had following probably the consumption of contaminated food. I don't know, but following these episodes of gastroenteritis, they developed some malnutrition.
yeah, excellent, sir. Because one thing that personally I am also facing such a situation here in Dubai, we can do bariatric surgery with BMI 40 plus 35 plus one comorbidity and 30 plus two comorbidity. We can go for surgery. Just imagine a patient with BMI 37 with diabetes. We did OAGB. Okay, everything was okay. There was no then diabetes. 3 4 years patient touched that BMI 25, but now patient BMI is 26 27, but diabetic. Any what we will do in this case? Patient is 27 28, but again
If
diabetic.
I would manage with surgery here in Italy a patient that is 26 or 27, even if he is diabetic, I would be sentenced to jail. This
Ah,
is absolutely
okay,
forbidden by our guidelines, and I would put myself in a very nasty situation. But yes, these are the rules here. But what I can tell you, it is very uncommon that diabetic patients or even their physicians requires my attention for patients having a BMI that is less than 30. The discussion here in Italy starts with diabetic patients when they are normally when they have normally a BMI that is higher than 35. Not before, never. It's very uncommon that a lightweight patient but diabetic asks for your attention if he's between 30 and 35.
definite. Then because this is also message for our youngster, there is no need to rush for surgical intervention. Definite, we have medicine, quality of life, and also as well as healthy lifestyle that is more dominant. Sir, regarding because this is the question also not more common in one anastomosis gastric bypass. So that is internal hernia. Have you faced any such a situation?
I can be appear, I don't know, not fair, but believe me, I've done probably more than 1,000. I've never seen an internal hernia following one anastomosis gastric bypass. I've seen some reports described in obesity surgery, the journal, or other papers in other journals reporting, but they are, I believe, they are anecdotal cases. Once again, I've never seen an internal hernia following one anastomosis gastric bypass. That is one of the advantages you have this following this surgery. Well, in my opinion, when you do a one anastomosis, the Peterson space, of course, it remains open, it remains untouched, but due to the fact that you have no meso interruption, as that is what happens with the one-way gastric bypass, it's very uncommon. You have an hernia that doesn't come back in his standard position. I'm sure that often OAGB patients, their jejunal loops goes into the Peterson space, but there is no interruption of the mesos, the bowel loops come back in their normal position.
Yeah.
And this is probably the reason we see so few internal hernias.
So this is a definite that telescopic movement of small bowel, and sometimes patient has
Inside
vague
and back and forth, back and forth. The patients probably may complain of of
vague-
some some pain or some digestion, but once again, I've never had to bring my patients in the OR to revise a case of internal hernias, at least so far. I don't know tomorrow.
Yeah, it's definite. Sir, regarding dumping, because that is also sometime a issue. I know your technique because when I interview you in MGB OGB series, and you have showed me that your technique, especially the size of that gastrojejunostomy. What is your experience about dumping? Is it common in your patients?
Well, once again, this is another of the advantages we face following the one anastomosis. In the Roux-en-Y, we have much more damping than we have in the OAGB, and this is probably due to the length of the gastric pouch and also the treatment that the food receive inside the gastric pouch when the food comes in contact with acids and with bile, and it is prepared more slowly to the passage into the small intestine than as it happens with the one-way gastric bypass, in which we have a very short pouch with probably no acid inside. So in my experience, I've seen very few dumping cases. And well, in general, when needed, I asked help to. So far, I faced 6 cases. I asked support to the endoscopic team to make a revision of the anastomosis and to slower the discharge of food inside the small intestine.
Yeah, excellent. Sir, now personally, I am facing a case after MGB nizidoblastosis.
Uh-huh.
I am also facing now one of my case. She's a lady, and what I do, I don't know, because previously I remember so many article and surgeries that, but that is aggressive. So what we do in such a case?
Well, I must be honest. I've never faced such a case of nesidioblastosis, and I've seen some reports, and well, must be honest. Is a big issue. Is a big
Yeah,
issue, and given an answer is not easy. Is not easy. What we should consider is it is very very rare.
yeah.
Very
Then change to sleeve or normal anatomy, or I have no idea, but because always the GI giving.
probably convert to another to normal anatomy,
Yeah,
especially if the patient has got an appreciable weight loss, can be a solution, but who knows? Is very uncommon.
yeah. Sir, so much thanks really, and it was definite one of the best session, and also special thanks. You are always sportive. You are always sportive. We need your support again, sir. We need your support. And one thing that I must highlight, as you know, we have started GLR ebook, and
Okay.
also I will share with you the connect. Please add your videos and short videos. Also, some we need some picture, some text, and also your short. You will be author of that book. We need again your support. Sir, your message for our youngsters who are just now going to start revisional bariatric surgery or still are newcomer in bariatric surgery. What they must do.
Well, they must be very cautious, and they must have a clear indication to revisional surgery. Don't put yourself into a revision if you have not a clear indication. And do not forget that the indications come from our general surgery practice. That is what we have learned in the past.
Sure. Sir, another, so my request, so we are going to start GLR link that will be this Sunday, last Sunday of every month that we are going to start. So Dr. Tansir will be moderator of that session. This is like MDT. So if you have any complication, how you must solve, and also we need your support in those sessions that will be every month, every last Sunday of every month. We also need, sir, your support. And in future, so fellowship program, again, we are going to start because now COVID era finished. We have a lot of applications. So again, I will stay in touch with you.
You are full of ideas and initiatives. So happy to help, happy to be part of your project. No problem. You have my email, so write me whenever you want, and I'll be happy to support your project.
Sir, so much thanks, and hope see you soon also in another international conference, and especially in your city in Italy.
Great. I'll be waiting for you.
Sure, sir. So
Ciao. Ciao. See
thank you,
you.
sir.
Ciao.
Thank you, sir.
Ciao.
Thank you.
Ciao.
Have a nice day.